sharing and turn it over to you.
All right, thanks, Dalton. Let me share my slides. I have a bunch of them, but I'll make sure we have plenty of time for questions too. Okay, so we're going to be talking about risk stratification in myelodysplastic syndromes, which is a really important part of how we as clinicians view our job taking care of patients with MDS, because it turns out that assessing risk is one of the key pieces of information that we use in order to determine how best to treat patients. These are my disclosures. And I'll start by taking a step back and actually just giving an MDS overview. I know that may be a little bit basic for some of you, but in case there are folks here who really haven't heard this, I'll give it to you from my perspective. I'll talk about how we make the diagnosis, how we classify MDS, and how that's different from assessing risk in this disease. I'll focus on mutations, DNA mutations, that strongly impact prognosis and sometimes give us some insights into how to treat patients as well. And I'll talk about our most powerful tool for assessing risk in patients with MDS, a tool called the IPSSM that we'll go into in great detail. And then I'll end by talking about some of the things that help us assess risk beyond the IPSS that we can use in everyday clinic. So let me start with that MDS overview. MDS, as you know, is a disease of the blood-forming cells in the bone marrow. And it really begins with the most primitive of these cells that we call a hematopoietic stem cell. That's all the way to the left in this figure. You can see that little loop back on that cell. That implies this very unique capability that hematopoietic stem cells have, blood stem cells. They have this ability to divide and make a perfect copy of themselves. Most cells in our body, when they're dividing, they're turning into something else. They're undergoing a process of maturation or differentiation, as we call it. They might be turning into hair cells or gut cells or skin cells, or in the case of blood, they're turning into mature blood cells. So we keep that in mind that even though stem cells can give rise to all the cells in our blood system, all the white cells, red cells, and platelets, they also have this capability to self-renew because that's actually where things go wrong in MDS. So if we take a zoomed in view of that, we can take a look at one of these stem cells that again has that capability to self-renew, to divide and make copies of itself. And that's tightly balanced with this need to mature or differentiate to turn into the blood cells. And this balance, which is very tightly controlled by our needs at the time, can become corrupted when these stem cells acquire mutations. So mutations that occur in the DNA of these stem cells might change their behavior. It might make them divide and replacing themselves more often than they should, and they start to accumulate. They start to crowd out other normal stem cells. But often these cells still retain the ability to differentiate. And depending on what those mutations do to that cell, we see different diseases. So in the case of a disease that we call chronic myeloid leukemia, the mutations in those stem cells that increase the number of stem cells actually drive the overproduction of stem cells. So those patients have too many blood cells. But in the case of MDS, it's almost the opposite. Those mutations that drive the overproduction of stem cells cause an impairment in the maturation process. So the cells are not as efficient. They don't do a good job maturing, and you get too few cells in the blood. It's almost like a paradox where you have too many cells trying very hard in the bone marrow and too few cells in the blood. And unfortunately, this is not a static process. You get this continuous evolution where additional mutations can accumulate and they can impair that system more. And in some cases, they can lead to the accumulation of cells that don't even know how to differentiate or mature. These are leukemic blasts, we call them, or leukemic cells, and that becomes secondary acute myeloid leukemia, which some patients with MDS have a risk of progressing to. And that's what we're going to focus on today is how do we determine what that risk is? Now, the way we actually get at this information is by doing a bone marrow biopsy. If several of your patients with MDS, you're overly familiar with this procedure. But the goal here is to be able to look at the cells in their home, where they reside, and how they are related to each other. How are they organized in the bone marrow? Is there scarring? Are there the normal cellular elements that we would expect, or are there abnormal cells there that shouldn't be there? And then we look at the cells themselves. We look at their shape, their size, their state of maturation. We look at their chromosomes to see if chromosomes are missing or duplicated. And then we look at the DNA itself. We do DNA sequencing in order to determine if any mutations are present at that DNA level. And back when I started in this field, I guess now over 20 years ago, as I was recently reminded, we didn't know very much about the mutations that gave rise to MDS. These were the genes that we knew about could be mutated, and we would see mutated in different patients, but they only accounted for a minority of patients. But since then, we've learned that there are literally dozens of different genes that can be mutated in MDS, and several of the ones that we didn't know about are actually much more common than the ones that we did know about 20 years ago. So now we have a wealth of genetic information about this disease. We know that many genes are mutated in MDS, and we know that some of these mutations are fairly frequent. We see them in 10, 20, or even 30% of patients with MDS. Now, there is no mutation that is found in most people with MDS, but we now have a good sense of what these mutations do and how they impact the progression of disease. And that's how we are now able to incorporate them into our risk models. So let's talk about what you do next after you make a diagnosis of MDS, because what your doctor may have done is then done something called disease classification, where you put this MDS into a different bucket, a different subtype. And that does help us understand a little bit more about the biology of the disease, but I'll show you how that's different from determining risk. We do know that assigning MDS subtypes does have important impact on risk. These are called survival curves. They show that at time zero, everybody is alive. 100% of the people are alive. And as time goes on, unfortunately, some people pass away and the curves start to go down. Some curves drop much more quickly than others. And you can see the curves that drop very quickly are those associated with subtypes of MDS that are more aggressive. So we know that classification does have prognostic significance. But there are other factors that come into play as well. For example, how many bone marrow blasts there are. The more bone marrow blasts that are present, the more quickly that this curve drops off, meaning that patients don't live quite as long, and the more likely they are to develop acute myeloid leukemia. And the fewer blasts that patients have, then the longer that they live. And we can also look at blood counts, and blood counts do the same thing. The more profound that the blood counts are low, the more we call the greater the anemia, or the greater the low platelet count, or the greater the low neutrophil count, the more likely a patient is to progress to acute leukemia. So this information is out there, but we didn't have an easy way to integrate it until we came up with what we call prognostic models. And I'll go through a couple of those with you. So what classifications do we have for MDS today? The most recent one was updated in 2022. We updated it from the 26 classification that I'm showing here on the screen. And what we did there is we put patients into bins based on, first, how many bone marrow blasts did they have? How many of these primitive cells were in the bone marrow? And patients that had 5 to 9% blasts were classified as MDS with excess blast 1, and 10 to 19% were considered MDS with excess blast 2. And then everybody who had less than 5% blast was then subdivided based on other features. They could be subdivided on dysplasia or abnormal looking cells, or the presence of these funny cells called ring sideroblasts that are shown in this picture with those little blue dots. Those are deposition of iron around the nucleus of the cells that indicates a very particular type of MDS. And then there was a type of MDS where they had deletions of chromosome 5, specifically the Q arm of chromosome 5. And these patients were important to identify because there was a therapy that was particularly effective in these patient populations. And as you can imagine, there are differences in risk associated with each of these different groups. Now, in 2022, we actually had two competing classification systems arise at the same time. One, again, from the WHO, the World Health Organization, and they left their system fairly similar to what they had before, but they started to incorporate some more mutational data, some more of those genes that we knew about in MDS. And in fact, that category of patients that had MDS with ring sideroblasts with those little blue dots around the nucleus, we noticed that most of those patients had a mutation in a gene called SF3B1. So that category became renamed essentially. It became MDS with SF3B1 mutation. We also identified a category of people who had mutations of a gene called TP53. And these people had a very poor prognosis independent of their blast count. So if they had high blasts, medium blasts, or low blasts, these patients unfortunately did fairly poorly. So we thought it was important to identify them as a separate subgroup so that we could maybe direct them to clinical trials or try new therapies or treat them more aggressively if need be. So there was finally one other category called MDS with fibrosis that we won't talk too much about today, but the idea is that these classification schemes were evolving, but they're based on looking at hundreds or even thousands of patients in order to determine what subtypes make the most sense. The competing classification scheme from the International Classification Committee was very, very similar to that from the WHO. There's some subtle nuances, but I'll just point out they also had this MDS with SF3B1 subgroup, and they also had this MDS with TP53 mutation subgroup. So we're starting to see these mutations come into the classification scheme a little bit more fully than they had in the past. Now, if you take these new groups that were identified in 2022, and on the left are the groups in the WHO, and on the right are the groups in the ICC, you can see that they have very meaningful differences in survival. You would much rather have disease that's on this blue curve here on the right, where patients live quite a long time after their diagnosis, compared to people who are on this purple curve on the left, which is associated with those TP53 mutations that I mentioned earlier, where people unfortunately don't live very long with their disease. But what I'll point out is that these curves were generated by looking at, again, hundreds or even thousands of patients in some cases. They don't really take into account every individual factor of the patient who's in the clinic in front of you. So we need to think about other factors that might contribute or can be incorporated into risk stratification. So these classification systems, I think, are useful. They identify patients that have similar disease biology and similar disease evolution. They also capture patients that have similar sensitivity to treatment. So your disease classification can help you determine what treatment is best for you. But these treatments are not personalized, and classification is not the same thing as risk assessment. So a doctor newly diagnosing a patient with MDS will go through risk classification, and they'll immediately follow that by doing a formal risk assessment. And that's what we'll spend most of our time on today. So how do we do risk assessment for MDS? This turns out to be very important because there are many, many treatment options for MDS, and they're not all appropriate for everyone. Some patients don't require treatment at all when they're first diagnosed. They could really receive just simple observation. Those patients would obviously have lower risk disease that's unlikely to turn into acute leukemia. And then there are treatments that are much more aggressive. On the other end of the spectrum, patients can undergo a stem cell transplant where they receive donor stem cells that are compatible with them to try to reconstitute their hematopoietic and immune systems. And those treatments would not be appropriate for someone who has very mild disease. And then there's all these things in between that have various degrees of aggressiveness, so to speak, associated with them. The NCCN guidelines, which are National Comprehensive Cancer Center guidelines for MDS, tell us that we can divide MDS roughly in half, where half of the patients have lower risk disease and half the patients have higher risk disease. And the treatment pathways for these two different risk groups are very different. They start with very different approaches. The higher risk patients obviously get more aggressive treatment. Those are the ones who were referred for transplant. And the lower risk patients get more supportive care or less aggressive treatments. So it's very important to try to identify risk appropriately in a patient. And in the past, I think we weren't doing a great job of that for some patients who were close to that middle ground. Those patients that had some intermediate risk had maybe perhaps some hidden features that might have actually made them higher risk or lower risk had we known about them. And I think we have a better handle on that today. So one of the first tools that helped us do this was called the International Prognostic Scoring System, was created by an international working group of MDS centers around the globe, where we identified certain factors that we thought were very important in prognosis. One of them was whether or not a patient had abnormal chromosomes. That's what we call the cytogenetic or karyotype risk group. And the other was whether patients had increased blasts in the bone marrow. And then finally, we asked if a patient also had abnormal blood counts. Did they have anemia, or did they have anemia and low neutrophil count? And those things would be associated with risk. And you can see here on the right that, roughly speaking, half the patients would have lower risk disease, or maybe two-thirds. Those would be the ones in the low or intermediate one risk groups. And the ones who were intermediate to or high risk would be considered higher risk. So we almost divided them right down the middle. But we learned pretty quickly that that system was a little bit flawed. If you used a more nuanced risk stratification system in the people you thought had lower risk MDS, you could identify about 31% of them that actually had greater than low risk disease. And we validated this independently in our own lab and found that to be roughly the same. So there were certain factors that weren't being considered by the IPSS, the first International Prognostic Scoring System, that could be improved upon. So when next we had the opportunity to do so, we included new factors into the risk stratification and came up with a slightly more complicated model. This was the revised IPSS, what we called IPSS-R, as you can see there on the right. And there, we again incorporate chromosomal abnormalities, just like are shown in this picture of chromosomes, where certain chromosomes are missing or certain chromosomes are duplicated. And we became much more granular. We included many more abnormalities so that we could understand better the differences in risk. And then we added bone marrow blasts again, but now we included each individual blood count, hemoglobin, platelet count, and neutrophil count as independent contributors to risk, and added all those things up to come up with a risk score. And instead of putting patients into one of 4 risk groups, we put patients into one of 5 risk groups. And the survival of these patients was dramatically different. The people with very low risk disease had survival that was almost like what you would expect for a person of that age absent MDS, whereas people who had very high risk disease had disease that resembled more like metastatic lung or breast cancer. Actually, I should say metastatic lung or pancreas cancer, very aggressive cancers. There was a huge difference in these survival outpoints. But there were some limitations of the IPSSR as well. First of all, it only considered untreated patients, and we'll come back to that point later. Patients who started to receive treatment around the time that the original IPSS was becoming out of date might have different survival than the patients that were included in these older studies. And it didn't take into account anywhere those DNA mutations that I told you we knew so much about, because at the time that this was created, we didn't have as much knowledge as we do today. So we thought we could improve upon the IPSSR by creating its next iteration that took into account those mutations. Now, roughly speaking, we divided the IPSSR into lower risk patients by splitting the intermediate risk group in half, and then having that higher part of the intermediate risk group, high and very high risk groups, fall into the very high or the higher risk category. But there was some ambiguity about what to do with those intermediate risk patients. And I think that's where mutations really help the most. If you have a person who's straddling that lower risk, higher risk line, knowing what mutations they have can help you understand clearly which side of that line they're on. So, how do we know that mutations impact prognosis? Well, one of the studies that we did many years ago was looking exactly at that, where we sequenced patients with MDS to identify what DNA mutations they had. And we said, do the mutations tell us something about the patients that we didn't know already? So if we took patients who had, for example, lower risk disease and divided them into those that did have mutations, that was this dotted line here, their survival was not as good as patients who didn't have adverse mutations. And in fact, the low risk patients who did have mutations looked more like intermediate one risk patients. And if we repeated that exercise with intermediate one risk patients, the ones that did have mutations didn't live as long, and they looked a lot more like those patients that had intermediate two risk, essentially higher risk disease. And we could even do that with patients who started with intermediate two risk, and if they did have adverse mutations, they looked more like they had high risk disease. So the idea was that by looking at mutations, we could upstage patients. We could put them into higher risk groups than we otherwise thought they would be in simply by knowing their mutation status. It was clear that mutations had independent prognostic significance. Now, we did that originally with the IPSS. We did it with the IPSSR as well, as shown here. These are the genes that we looked at, just a small number at that time. But again, the patients who had mutations, their survival shown on the red curve, and in every case, that survival was shorter than it might be for patients who didn't have mutations, shown in the black curves. And it didn't matter if patients were in the very low risk group, where about 20% of patients had adverse mutations, or in the low risk group, where about a quarter of patients had adverse mutations, or in their intermediate risk group, where about a third of patients had adverse mutations. Whenever those mutations were present, the survival was not as long as we might have thought it was going to be. Now, this has been repeated many times. As I mentioned, now we know not about 5 genes that are adverse, but we know closer to 48 genes or 50 genes or even more that are recurrently mutated in MDS, many of which have prognostic significance. And just looking at the mutations, these two studies from 2014 could stratify patients into different risk groups. So we knew that these mutations were really important. So in around 2020, we set out to look at this more formally. And we created the newest iteration of the International Prognostic Scoring System, the Prognostic Scoring System M. M stands for molecular, referring to the DNA sequencing that we were now able to do more cleanly. And again, this was a global effort. Centers all around the world, both in the US and in Europe and in Asia, contributed patients and DNA samples from patients who had agreed to participate in this research to this concerted effort that was done by Dr. Elsa Bernard and Ellie Papamonuel out of Memorial Sloan Kettering in New York. They had looked at MDS, understanding the mutation profile of these patients. They found that they could identify mutations in 94% of patients thought to have MDS. And that's much more than, say, for example, chromosomal abnormalities that are only present in about half of patients. And most patients had more than one mutation. So most patients had 2, 3, or even 4 mutations on average. And the number of mutations turned out to be prognostic as well. So here's an example of what we could do now with this really rich information. We knew that SF3B1 mutations were very common in MDS. They occur in about 25% of patients. But we saw that some people had SF3B1 mutations by themselves. Other people had SF3B1 mutations that were associated with a chromosomal loss, like deletion 5q. And other people had SF3B1 mutations that were associated with other mutated genes. And it turns out that the people who did really well were the people who only have that SF3B1 mutation. Their survival shown here on the purple curve. And patients who had SF3B1 mutations plus other mutations or chromosomal abnormalities, they didn't do as well. They did about as well as patients who didn't have either of these lesions. So we now had enough information where we could actually get very nuanced about what mutations contribute to risk and how they contribute to risk, and we could make a much more precise model. So the model is shown here. It's very complicated, and even I don't have this memorized in any way, but it just highlights what it is that we look at. So we consider age, sex, the type of MDS that people have, but the most important factors still remain how many blasts are in the bone marrow, very important to know. What are the platelets and the hemoglobin doing? It turns out that the neutrophils become less important once you know all the different genetic mutations. And then what genes are mutated? And we looked at 17 different variables from 16 different genes. And we split apart that SF3B1 group based on whether it was SF3B1 by itself or SF3B1 plus other abnormalities. And then we looked at another 15 genes and just counted them and said how many of these are mutated. And that added a small amount of risk if it was a large number. So putting that together, we came up with this spectrum of risk. And the height of this curve here shows how many people have a particular risk group. And you can see that most people tend to have low risk or very low risk. About, I'd say, a third of people might have what we call moderate low or moderate high risk. And then the remaining people have high or very high risk. And 0 is considered middle, intermediate, and anything positive is considered higher risk, and anything negative is considered lower risk. So it made it a little bit easier to make that lower risk, higher risk designation. And now we created 6 risk groups. And then this again allowed for an easier split between the risk groups because we could divide the top 3 into higher risk and the bottom 3 into lower risk. And you can see these patients again have very meaningful differences in overall survival, where half of the patients with very low risk were alive 10 years later, but only half of the patients with very high risk were alive 1 year later. So very significant differences in outcome. It performed better than the IPSS-R, the previous model that we had before it. And when we re-stratified patients, we took patients from the IPSS-R and said, well, what is your IPSS-M risk? We found that it moved people by 1 or more risk groups quite often. And we could repeat this in an independent risk group from the Japanese population that tended to be a little bit more higher risk overall, showing that this was a constant feature. And about 46% of patients actually got re-stratified one way or the other. Most of the patients were stratified upward, with some of them being actually stratified downward. And 7% of the patients actually moved to different risk groups. So this became really important because now we could ask questions about whether these people who really have genetic risk driven by their mutations, are they appropriate for more aggressive therapies? Are they more appropriate for stem cell transplant, for example? And if you knew that they weren't going to do well, that was certainly a good thought. Here's another way to look at what we did here. We took patients who we thought had very low risk by the IPSS-R, and we re-stratified them using the IPSS-M. And you could see that it separated these curves very nicely. That happened again if you started with people who were IPSS-R low. You could even find patients who had very high or high risk in that population, and so on and so forth. But if we try to do the reverse, if we try to take people that we stratified with the IPSS-M and re-stratify them by the IPSS-R, then the curves didn't separate, meaning that the IPSS-R didn't have the ability to distinguish risk better than the IPSS-M did. The IPSS-M was really capturing all the information that we could capture, and the IPSS-R didn't add anything. So we now consider the IPSS-M to be the gold standard for risk stratification in MDS, and it's what I use in my clinic. And I'll show you how we actually use that because I use it with my patients. Some things to know about this, though, are that there are some differences between the IPSS-M and the IPSS-R. One of those differences has to do with patients who get treated. So in the IPSS and the IPSS-R, all the patients that we used to create those models had never been treated. So their survivals are really reflective of no treatment. Whereas in the IPSS-M, 30% of patients receive some sort of treatment. So maybe this is more accurate in part because it's taking into account the survival after therapy. But there are certain subgroups of patients for which the IPSS-M is still not the best tool. For example, patients who have an MDS-related condition called chronic myelomonocytic leukemia, or CMML, who have a really high white count, those patients don't perform very well on the IPSSM. There are other dedicated scoring systems that are more appropriate for those patients. Similarly, patients who have germline mutations, meaning mutations that they're born with that predispose them to get MDS, like mutations in a gene called DDX41, their risk is not well captured by the IPSSM. These patients actually have a very high risk of developing leukemia, but their leukemia tends to be very sensitive to treatment, meaning that they tend to do very well with therapy. So the IPSSM overestimates their risk and is not a good tool for that patient population. So with these little nuances in mind, I still think the IPSSM is the best tool, except for these corner situations. It even works in people that we didn't really trust the other prognostic scoring systems to stratify very well. So, for example, in people who have therapy-related MDS, disease that comes after a prior cancer treatment, for example, or prior radiation treatment, we always thought that these patients, they had much worse disease and they were more difficult to treat and they were more likely to relapse and they were more likely to die sooner. However, once we understood the mutations that these patients were likely to have, then the picture became clear. Their disease risk wasn't driven by the fact that they had prior chemotherapy or radiation. Their disease risk was driven by the fact that those treatments created worse or more adverse mutations in their bone marrow, leading to more aggressive disease. But once you took those mutations into account, there was no difference in survival for people who had prior therapy and people who did not. So this made it a lot easier we essentially removed the necessity for trying to determine whether a patient's MDS was caused by a prior insult or not. We would just treat you based on your mutation profile. In each of these different subgroups, whether or not you had therapy-related disease, the survivals were very similar. Now, this has been repeatedly validated. I'm just showing some validation curves from other groups who have their own MDS patient cohorts that they've studied and then applied the IPSS M2, and they show a similar rate of restratification from the old systems and very good survival separation. And this is true even in patients who go on to receive a stem cell transplant. So this tool looks like it's not just useful at the time of diagnosis, but it's useful when patients are being considered for stem cell transplant or when patients are undergoing therapy. And like I said, it's been validated in multiple parts of the world as well. So both in Europe and in Japan and in the US. So we do think it is a very robust tool that really does apply to most patients with MDS today. And this is, again, it's also been validated in those patients with therapy-related MDS or TMDS. Now, how do we actually apply the tool? Because as I mentioned, it's pretty complex. Those earlier versions, we could just look up at a table and say, well, the blast count is whatever, and then we could figure out how many points a patient gets. But this is a much more, I think, opaque tool. We don't really memorize all the different weights of everything. So what we do is we go to a website, shown here, mdsriskmodel.com, that you could actually just do a Google search for IPSSM. It'll be the top hit. And you can put in patient information there. Like, for example, how many blasts do they have in their bone marrow? What is their hemoglobin? What's their platelet count? What's their neutrophil count? How old are they? Then on the next page, you can put in what kind of chromosomal abnormalities do they have, if any. And you can see that people might have, if they have a normal chromosomal complement, then they would be in the good cytogenetic risk category. You click that button. And then lastly, you go to the molecular data button where it asks questions about mutations. And the first question they ask is, does the patient have a TP53 mutation? Remember, that's that gene that's associated with a very poor prognosis. So it's the most important one to find out about. And it's important to note whether the patient has 0, 1, or 2 mutations in TP53, because it turns out that if both copies of TP53 are not affected, those patients actually do better. Whereas if one copy of TP53 is affected, or no copies of TP53 is affected, there must be one remaining TP53 allele that's normal, and those patients do well. But if both are affected, if both A and B, the parental alleles, are affected, then those patients tend to do more poorly. Finally, it asks about the presence or absence of a bunch of other mutations, and you just click the radio buttons. Is it mutated? Is it not mutated? Or is it not assessed? Sometimes patients won't have every single gene mutation in our list assessed, and that's okay. The model will still work. And then it'll spit out the patient's risk group. And in this example, this patient has high-risk disease. It gives an estimate of the leukemia-free survival or the percentage likelihood that they will develop leukemia in 1 year, and it shows where they are on the survival curve. And it gives you both the IPSSM and it calculates the IPSSR, that older model that I mentioned. So you really get both in one shot. So actually, I go through this exercise with my patients in clinic to help them understand how I'm perceiving their risk. And it also helps frame the therapies that we then talk about. Because if I tell a person who's very concerned about their new diagnosis of MDS that good news, you actually have very low risk disease, it's unlikely to progress in the near term, they may be less concerned about the fact that we're not doing anything to treat their disease at that moment because it's not appropriate. However, if I have a patient with higher risk disease, that we go through this exercise and it shows that, the risk of developing leukemia in the next year is something on the order of 15%, and we want to try to prevent that, then they might be much more willing to consider a therapy like azacitidine or another hypomethylating agent that involves a big change to their life. It involves coming to clinic more often, undergoing the side effects of that therapy, and getting all the associated treatment that comes along with it. So the risk factor determination here, I think, is a really important way to frame that conversation about therapy because we use it to help determine what therapy is most appropriate for people. So again, that tool is mdsriskmodel.com, or just do a Google search for the IPSSM. And like I said, you don't have to have every piece of information that the model incorporates because it's tolerant to missing data. So for example, in this example, we didn't sequence BCOR01. We say that gene was not assessed, and it just gives you a range of where the risk is. And you can see that it doesn't really change the risk very much if that gene wasn't assessed. Whether it's mutated or not, the risk is pretty well established by everything else. So this is a good tool for really all scenarios. Now, I use that tool, but it's not the only thing I think about in terms of risk. There are other factors that become important, and we can't incorporate them all into the model, but we can think about them in parallel. One of the ones that I think is really underutilized is this concept of frailty, that there are a lot of factors that have nothing to do with the disease, that have a lot more to do with the patient, that have a huge impact on prognosis. And some great studies done out of Rena Buckstein's group in Canada have really, and Goya Abel's group in Boston have really highlighted this. And they came up with this study published in 2019 that looks at comorbidity and frailty in patients with MDS to determine how that affects their overall survival and information that we can then use to help decide how to treat these patients. And this tool considers many patient factors and considers their weight, their heart, lung, and brain function, whether they have diabetes, what is their mobility like? Do they have anxiety or depression? How are they about doing their daily activities and their self-care? And then some actual physical factors like what is their grip strength? How fast can they walk a 4-meter walk? How quickly can they get up and down from a chair 10 times? These factors turn out to be remarkably important. And when you put them all together and come up with a score, you show meaningful differences in survival, where people who have a lower score, meaning fewer of these adverse things, they do substantially better than those that have higher risk. And even if you think about their risk from the IPSS-R first, you can stratify patients again, meaning that this adds new information. Now, if a person has very high risk by the IPSS-R, probably their physical well-being at that moment isn't going to overcome the disease-related risk. But for people who have low or very low risk by the IPSS-R, the majority of their risk is actually determined by their personal factors and not necessarily by their disease factors. So it's important to take these into account. And the last thing I want to say is that we have to be very careful of using these tools that were designed now 5, 10, 15 or more years ago at the time when we didn't have all the therapies that we have today. I mentioned that earlier, that those earlier tools like the IPSS and the IPSSR were created at a time where we didn't treat patients very often because we didn't have great therapies for MDS. And now that we have more options available, these therapies are making an impact on prognosis. So I'll give you an example of where that really made a big difference in a related disorder, in acute myeloid leukemia. So this is from 2022, when the European group decided they would take a good look at leukemia and they would do a risk stratification for leukemia based on genetic features. And this is what they came up with. There's a favorable group, an intermediate group, and an adverse group. And if you'll note, there is two groups of people who have MDS-like disease. This is AML with myelodysplasia-related changes, and sometimes it's AML that came after MDS. And most of those people had adverse risk disease in this older 2022 risk stratification tool. Down here at the bottom, we still have those mutated TP53 patients, and unfortunately, those haven't moved very much. But here's the thing to know is that AML with myelodysplasia-related changes, as little as 4 years ago, was considered to be largely an adverse risk AML. And here is the survival curves using those tools. They look pretty good. They put patients into really 3 different groups very cleanly with very little overlap. And that was true even in an independent German validation. So it looks like this really matters. But the thing to keep in mind is that most of these patients were treated with the therapies available at the time, largely with chemotherapy. What if we used a different treatment option? And after additional analysis, we learned that there's a new therapy that combines azacitidine and a new drug, venetoclax, puts them together, and that improves survival. So patients who got venetoclax, their survival is on the green curve. Their survival moved to the right, meaning that these patients live longer. So this new therapy made an impact. And when we looked at who benefited from this therapy, it wasn't that old system that predicted that. So they came up with a new system where, again, unfortunately, the TP53 mutated patients are on the low end of that spectrum. But the short story is that the new stratification scheme that they came out with just 2 years later in 2024 now put most of the AML with MDS related changes in the favorable or intermediate risk group, where they used to be largely in the adverse risk group, meaning that the advent of a new therapy that had better outcomes for patients with MDS related disease has now changed how we think of the risk classification for them. So we have to keep in mind that as new therapies come along, these old predictions from these effective models may not be as accurate as they once were. Unfortunately, TP53 is still down here at the bottom, and we're working hard to figure out better options for that patient population. Now, that combination of drugs that I just mentioned, that hypomethylating agent, azacitidine plus venetoclax, has been tried in MDS and unfortunately did not show a survival benefit in its first study, but we're hopeful that in some specific patients it may turn out to be better because it did show a better response rate. So keep in mind that these changes may be around the corner as well. Finally, there's another drug that was approved just a couple of years ago called imetelstat that may be an example of a drug that changes the prognosis curve for patients with MDS. It was designed to treat patients who have anemia with lower risk MDS. But one of the things we observed is that when the drug worked, when people's anemia improved, their burden of disease went down. The proportion of cells that carried adverse mutations actually went down, suggesting that we were impacting the structure of the disease. And who knows, if this turns out to change survival in this disease, it may also impact how effective those predictions we make using the IPSSM are in the future. So I'll end there. I'm talking about MDS subtype classification is useful, but is not the same as risk stratification. The best tool to use today is the IPSSM, which you can do in your doctor's office, or you can do at home. And it's valid in a variety of contexts at the time of diagnosis and beyond, but it doesn't consider absolutely everything. So your doctor isn't going to stick by that as the final truth if they know more about you on a personal level. And that novel therapies will change how effective these tools are, so we'll be reshaping them as we go forward all the time. So with that, I'll end, and I thank you for your attention, and I'm happy to take questions.
Thank you, Dr. Bejar. That was wonderful. So easy to follow along with and incredibly informative. So let me go ahead and pull this up. Now is our time for questions. So if you have questions, please feel free to drop those in the chat. I do see one question in here already. And this individual is saying or asking, have retrospective studies been done to apply the IPSSM to patient marrow samples who have had various treatment? That is, what are the overall survival curves for patients based on prognosis risk levels?
Yeah, that's a great question. So when they created the IPSSM, they didn't exclude patients who had received treatment. So already kind of baked into the model is some impact of therapy. But we then went back and asked the same question that you're asking is if does the IPSSM predict response to treatment? And the fact is it doesn't do so very well. That there are other factors that are better predictors of response than simply the risk group. But one of the things that we noted is that people that we used to think of as being very high risk because they had a lot of blasts, for example, might actually do better with certain kinds of treatment. So I mentioned the DDX41 mutated patients. Those patients tend to respond so well to therapy that their survival is better than their blood counts and bone marrow would predict. And patients who have another mutated gene called NPM1, for example, when they are treated with chemotherapy, also do better than we might predict. So this tool is useful for assessing what would happen in the absence of therapy, I think, largely, and can help us decide when therapy is appropriate, but doesn't necessarily predict which therapy will be the most effective.
Okay. And then the next question was, if a patient's unsure if they've had a full genetic panel in order to really utilize the IPSSM, how would they go about speaking with their physician, whether they're at a specialty clinic such as UCSD or a local oncology clinic, how do they go about having that conversation to say that they would like to request um, that genetic profiling?
That's a great question. I think we're fortunate now that genetic profiling or panel testing at diagnosis is fairly standard around the country. Most centers will do this. And even if a center like, we have our own test at UCSD that we send internally, but most centers will have access to commercial tests that can be sent to other companies. And there are a variety of the companies out there that do these tests. And it's not a mystery anymore. So if a person's newly diagnosed with MDS and has not had a mutation profile, it's not too late. It doesn't require bone marrow material. It can be done in peripheral blood. That opportunity exists. And most of these panels are now covered by insurance, recognizing that they add value to the care of patients with MDS. So you simply would ask your doctor, have I had a DNA mutation panel done on my blood or bone marrow after I was diagnosed with MDS to help determine what my risk is using tools like the IPSSM?
Okay. And then a follow-up And then a follow-up question to that one was, is it possible for risk to change over time? Can someone originally be um, a low risk or an intermediate one on the IPSSM and then go to higher risk over time?
Yeah, great question. Yes, risk can change over time, but it is not the case that someone who starts at low risk will inevitably march through all the different risk groups and eventually reach higher risk if they live long enough. We think that probably different MDS subtypes have different MDS biology and they have different propensities to change, but it doesn't mean that the risk can't change. So you can reapply the IPSSM at different times during a patient's progress with their disease. And so it may look better after treatment if a patient responds nicely, and it may look worse if there's been additional clonal evolution and new mutations have been acquired over time. But just like everybody with MDS doesn't go and get AML, not everybody with low risk MDS will necessarily get higher risk MDS.
And then next up, is there anything on the horizon for patients with TP53 mutation, especially those with a high VAF? Now that looks like megalimab has failed.
Right. Yeah, we were very disappointed with the magrolimab study not being positive, that it didn't show a benefit in patients actually with MDS or AML, and particularly for patients with TP53 mutations. So there is a great effort to develop new drugs to treat specifically this patient population and how to repurpose existing drugs that we have. Because people with TP53 mutations likely still respond to therapy at about the same rate. They just have earlier rates of relapse. So if a patient, for example, is appropriate for stem cell transplant, even though outcomes are not as good with this mutation, it's still a good option for those patients with TP53 mutations, but perhaps we would do something like a transplant plus some sort of maintenance or plus some new type of conditioning or plus some experimental therapy. We're much more prone to recommend a clinical trial for patients that have these mutations for which our existing therapies are not sufficient. But yes, there is an effort, both at pharmaceutical companies, small biotechs, and academic labs, to come up with novel therapies, perhaps therapies that engage the immune system, or perhaps therapies that engage novel pathways to try to treat patients with TP53 mutations.
Okay. Then next up, does active Epstein-Barr virus affect risk? And how does inflammation affect risk like an autoimmune disease?
So this is an insightful question because I didn't mention this, but many of the mutations that I talked about actually create an inflammatory environment in the bone marrow. So inflammation is part of MDS. Inflammation can mean many things. It's an umbrella term that can mean different types of things, but in the bone marrow, it means that certain inflammatory factors or immune activating factors are altering the normal microenvironment and normal cells maybe don't function as well. And if we could somehow put a lid on that inflammation, perhaps we could not only slow the progression of the disease, but it make the normal cells work a little bit better. Now, I am not familiar with data that suggests that Epstein-Barr necessarily makes this worse, but there is evidence to suggest that greater degrees of inflammation are associated with worse marrow function, whether or not that comes from Epstein-Barr or other causes. So I think if you have the opportunity to address inflammation caused by a particular cause, then it might be worthwhile. It could end up helping the MDS, but it's hard to know until you actually do that.
Right. And then the next question is DDX41 inherited? And then in parentheses germline, also is monosomy 7 and deletion 7q the same thing?
Great questions. Let me tackle the second question real quick because it has an easy answer. So monosomy 7 means that the entire chromosome 7 is missing, both the 7p part and the 7q part, which is what we call the two arms of chromosome 7. Deletion 7q means that some of chromosome 7 is still there, but the q arm, or the long arm, is missing. So it's a partial deletion of chromosome 7. Now, they have similar prognostic significance, not identical, but very close. They're treated the same in our prognostic scoring system, but they obviously are different events. And once we understand the biology better, we'll be in a better position to understand why those things happen. And then your other question for DDX41 mutations. So some DDX41 mutations are inherited, meaning a person is born with this mutation. It's not something that they acquired over their lifetime, like most of the mutations that we see in MDS. However, it's very common for people who are born with a DDX41 mutation to acquire a second DDX41 mutation on their remaining gene when they develop MDS much later in life. In fact, the average age of onset of MDS with DDX41 mutations is about 65. It's not something that occurs in a person's 20s or 30s, like other cancer predisposing mutations in MDS might. So it's a little bit unusual in that regard. But mutations can be both inherited in germline or they can be acquired later. And in some cases, a patient will only have an acquired mutation in DDX41 that's contributing to their disease, but it's probably not the only mutation.
Okay. And then we do have one more question in here. I don't want to go in depth because it is a little bit more personal, but
I can see it. I can try to answer it in a more general
okay.
term here. Um, So it's a person who's talking about certain specific mutations who has been diagnosed with what sounds like CMML based on their description, and that their blasts are fairly on the low side. So all this information is the type of information that we would plug into the IPSSM to try to figure out what the risk is. And it's something that can be done, after a bone marrow biopsy because you'll have that information fresh in hand. And like I mentioned before, if a person gets treated, certain factors could get better. Some mutations could disappear, some chromosome abnormalities could go away, blood counts could improve, and reapplication of the IPSSM, even though it wasn't designed to do that, may give you a better understanding of risk at that time after that response. I mean, in general, we know that patients who respond to treatment do better, and this would be kind of like a confirmation of that. So I think it is a useful tool to use even in that context, even though it wasn't necessarily designed to assess risk after people have gone through treatment. It was designed to assess risk at diagnosis, but we found that it has worked in many other contexts, even though that was the case.
And then this next one, and we have two in here, and we're probably going to have to finish off after these two. But the first one is, and I'm just going to go ahead and read this verbatim, but an ATNM trial shows a 95% probability of getting to allo versus 16% now. And also, GPS shows a 6-year life expectancy as a vaccine after transplant. Why not put this together as a trial?
Yeah, I'm not exactly sure which trials those are, but I I am generally in favor of combining different modalities. So if you have a therapy that you have to test in isolation, but you then discover that it's effective, trying to immediately combine them with other therapies that are either in development or already in use, I think is a really great idea because we certainly don't have any single therapy for MDS that is so good on its own that it couldn't be added to by adding another therapy. So I'm hopeful, especially things that work in very different ways, like for example, an immune engaging vaccine approach in combination with maybe a more cell targeted drug therapy approach, it would be a great combination.
And then can mutations change with each bone marrow biopsy?
So, like I mentioned at the beginning, the mutation profile of a person is not static. It can change over time. Sometimes additional mutations could occur, and we call that clonal evolution. And sometimes certain mutations, especially if they were small to begin with, could be outcompeted by new mutations. So those mutations could go away, so to speak, or kind of be swept out as new mutations grow and expand. And finally, therapy can certainly change that. That is, certain therapies, whether it be azacitidine or decitabine, or even imetelstat, as I showed you, that can affect the burden of mutations, then certain mutations could go away with therapy. Then also mutations could be acquired with therapy if the mutations make the cells more resistant to that treatment. So it is a constant evolution, and it's why I look at the mutation profile really whenever I do a bone marrow biopsy, which is whenever I'm contemplating a new therapy or I see a change that I don't understand that might be associated with disease progression.
Okay. And then this is going to be our last question, and I will generalize it a little bit, but if blood counts are normal and blasts are low, this person's specifically asking around 2% in the bone marrow, is treatment necessary rather than just addressing that one person? But um, how should an individual go about speaking with their physician about when treatment might be necessary for them and why treatment might be necessary at different stages, or maybe they shouldn't be on treatment yet?
Yeah, that's a good question because if a person goes through this exercise of the IPSSM and they come out as having high risk, for example, but they don't have very low blood counts, they're not requiring transfusions, they don't have any symptoms that they associate with their disease or with their low blood counts, then maybe treatment isn't required right away. There is time to either observe and see how things evolve, see if they're evolving rapidly or not at all. And there is time to consider maybe less aggressive treatments in a patient who otherwise might fit into that higher risk profile. So again, the IPSSM is a really useful tool to help decide which patients are eligible for more intense therapy, but it isn't the only factor that we consider. And these other things, like having normal or near normal blood counts and having low blasts, they're going to be part of that score, but they're also going to be part of the conversation we have with patients about whether treatment is required. So it's not just the score, it's really the interaction with patients and what we observe in the clinic that matters.
Um, And thank you again so much for your time. We are going to go ahead and wrap up our Q&A there, but this was so incredibly informative and well put together. So truly, thank you for taking the time to be here with us, and this was amazing.
I appreciate it. Thank you.
Of course. And as we're getting ready to wrap up here, I did want to let everyone know that we do have a quick survey that you can take after this event when you're logging off. Um, just give us a little bit of feedback about how you thought today's event went, future topics you'd like to see us cover, things, anything you'd like to see us change. I do read all of those, and it is really helpful for me when trying to figure out what our community really wants to hear about. So as you're logging off, please take a moment to do that. But I did also want to let everyone know that we do have a Black health community here at HealthTree. We understand that this is a community that really needs its own space, and we have a space dedicated to the Black health community. So if you are interested in joining, please let me know, or know anyone who may benefit from this group. Please let them know about it. It is a wonderful group, and we just want to raise some awareness about it. And then we do have a few upcoming events that I think may be of interest to our group here today. This Wednesday, we have Innovations in High Risk MDS. We learned a lot about how risk is assessed, so that'll be a really good follow up one here. But Innovations in High Risk MDS, Expert Insights with Dr. Jacqueline Garcia. That'll be this Wednesday, April 29th. And then on Monday, May 4th, we have a community gather event. So this will just be kind of bringing the MDS and CMML community together, um, having some positive shares. So great group always. So if you haven't joined, highly encourage you to do so and just meet and get to know some others with MDS and CMML. And then on Tuesday, May 5th, we have You're Not Alone, Financial Help for Clinical Trials and Mental Health Care for Cancer Patients. So a lot of things coming up over the next week or so. So I hope to see you all there. But as always, just thank you all for coming. My name is Dalton Bean, and my email is up on the slide here. Please feel free to reach out to me if you have any questions or you just want to talk. I am always available to you. But I hope everyone has a wonderful rest of their day. And thank you again, Dr. Bajar. This was amazing.